Welcome to AETCM, the Emergency Medicine Channel. I'm Shelby. Today we have received a 60-year-old female who had fell on an outstretched hand, ma'am. Okay. Initially, her vitals in the triage area are normal. She has been triaged into green area, ma'am. Right now, history-wise, patient today morning, while in the kitchen, while she was working in the kitchen, she had slipped on and fell on an outstretched hand, causing a swelling on her left wrist region, and pain was persistent, so she has come to our ER, ma'am.
Okay, so when all a patient falls with an outstretched hand, what all fractures will you suspect?
In the outstretched hand, we see the fractures of the upper limb, starting with the fractures containing to the wrist, that is Colles, Smith, Barton's and Choffer fracture, and then carpal bone fractures like scaphoid, triquetrum and capitate fractures are common. Again, fractures involving the forearm, that is Galege's, Montagia's, Essex-Loperty fracture, and distal radial head fractures are common.
Okay, so fallen on outstretched hand, most common DDs which you expect are?
Colles and scaphoid fracture.
Colles, scaphoid fracture, and there can be a shoulder dislocation also. So shoulder, anything can happen in the upper limb. Mainly we see the shoulder, Colles and this thing. So, how is Colles fracture different from Smith fracture?
Colles, it's about the angulation of the bone in the lateral X-ray. If the angulation is towards the dorsal side, it is Colles. If it is towards the palmar side, it is Smith's fracture.
So, what will be the mechanism in Smith fracture?
In Smith fracture, usually fall would be if the arm will be in the flexion ways. When he touches the ground with the flexion, then it can.
So, Colles mostly happen when the fall is on an outstretched hand like this, and so that the fracture will happen here and the distal segment will go dorsally. Okay. Smith fracture, the distal fragments will be going more into the volar aspect. So the fall should be like this. Fall on an outstretched hand with a flexed wrist.
Or back.
Flexed wrist. Or patient will fall in supine position. Supine position, patient will be falling and it will be dropping like this. That is how Smith fracture occurs. Then how does Barton's fracture occur?
Barton fracture actually is an intra-articular. Smith and Colles are extra-articular. They don't involve the joint space, but Barton and Choffer both involve the joints, intra-articular fractures.
So it is the intra-articular fracture of the distal radius.
Yes.
Okay. How does it happen?
Distal head of the radius and along with involving the radio ulnar joint.
Okay. So so we told fall on an outstretched hand is for Colles and fall on an outstretched hand with flexed wrist or a supine fall is for Smith fracture. So Barton's fracture will happen if there is pronation also. Along with the pronation, the patient is falling, then Barton's fracture can occur, and if there is excessive pronation, then Montagia fracture can occur. What is Montagia fracture?
Montagia fracture is ulnar shaft fracture along with radial head of the radius dislocation.
Is it proximal or distal?
Proximal.
Galege's fracture is distal. So if there is excessive pronation, there will be Montagia fracture. If just pronation, there can be Barton's fracture. Then along with that, if there is a fall on an outstretched hand with radial deviation, there is more chance for scaphoid to fracture. Scaphoid fracture, fall on outstretched hand. If there is more radial deviation, scaphoid fracture can occur. If there is ulnar deviation, perilunate fracture dislocation can occur if there is ulnar deviation. Okay. And one more thing is that if there is a forceful dorsiflexion while fall, then that can cause lunate dislocation also. So, lunate and perilunate dislocation, what is the significance?
In lunate dislocation, it's actually the other bones which are lunate is not.
No, it can cause some complications like there can be median nerve injuries that can cause carpal tunnel syndrome, and arterial injuries are also common. Okay, so that is with the mechanism. Okay, continue.
Right now regarding this patient, On history-wise, the patient had a fallen outstretched hand slipping in the kitchen, and it is a traumatic history. And on examination, head-to-toe examination, general examination is all within normal limits. Specific local examination, first we need to check, on inspection we need to compare with the other hand, whether there is any change in the contour and the difference in the joint deformity or anything. Then in this case, the patient is having a swelling around the wrist.
So what is a deformity called?
Colles is having dinner fork deformity.
And garden spade deformity
is in Smith.
Smith fracture. Okay. So you need to look for the any deformities seen along with
the swelling, abrasion, bruise, these findings. And next on, we ask for active movements and passive movements. Active movements are palmar flexion, dorsiflexion, and movements around the wrist. Then we check for the pulse. Palpate the pulse. If all the pulses.
Checking active and passive movement will be very painful for the patient. So once we see the deformity, directly look what deformity it is and directly go for the distal pulse.
Distal pulses. We can check for the capillary refill times to see if the pulse is present.
So next, in this patient, what was it present?
It was present, ma'am, and sensations are also intact. No neurovascular loss, anything.
Okay.
And then we can palpate the bony landmarks to see where exactly the tenderness of the fracture segment is palpable.
Okay.
Here the distal radius was having crepitus and mobile it was the distal radius. Okay. Then we ordered the X-rays, one AP and one lateral view of the wrist
joint. Why you asked for X-rays of the AP and lateral?
To see the angulation and the displacement and the fracture part of it.
So why can't you just take one X-ray, either AP or lateral?
In lateral only we can say whether it is palmar or dorsiflexion. In AP we can see if there is lengthening and shortening of the radial bone because of the fracture.
So in AP we can see the proximal shift of the radius can be seen. Who is more distal? Whose styloid is more distal, radius or ulnus?
More distal radius.
So during a Colles fracture, the radial styloid and the ulnar styloid will be in the same level. So we can see for the the proximal shift. Then what else can be seen in an AP X-ray?
In AP we can the dislocated part or the fractured segment
will be moved proximally. Along with that, we can see if it is moved more laterally or to the ulnar side. So in Colles fracture, it will be more proximal. Along with there will be a radial tilt and a radial tilt can be there mostly.
And then, even sometimes ulnar styloid can also be fractured.
In lateral X-ray, what will you check?
In lateral X-ray, we see whether it is palmar or the dorsal. Which side it is angulated.
Proximal shift also can be seen along with that dorsal or palmar. Okay.
In this case, we had seen that the patient was having 2 centimeters before the wrist joint radius is been fractured and it has been displaced anterior, like proximally, and as per also there is a dorsal angulation to that.
Okay.
And as the patient is
then what else will you check in
shortening?
The shortening. Then, as you told, ulnar styloid fracture. Then
any other carpal bone fractures? Like rule out other fractures.
Why will you look for other carpal bone fracture? So what makes the wrist joint?
The radius and the triangular articulating cartilage. Along
will
with
ulna make the
no, ulna will be with the contact with the cartilage, and cartilage is a point of the joint.
So radius along with the carpal bone, scaphoid and lunate will form the this joint, wrist joint, and radius is having which all articular surfaces?
Styloid side it will be.
So radius is having mainly 3 articular surfaces. One it will articulate with the ulna, one it will articulate with the carpal bones, and other is with the triangular fibrocartilage complex. So always suspect during a fracture, during a Colles fracture, always look whether the triangular cartilage complex is affected or not. And as in X-ray, we can only see whether there is any other fracture like ulnar fracture. And always palpate and see for the ulnar collateral ligament also to look whether it is injured or not. Okay, so you were talking about die punch fracture and all. What is that?
Die punch fracture is when there is intra-articular extension of the fracture line and stopping like it in the carpal bones.
Okay. In die punch fracture, either it will go into the radio ulnar joint or the radiocarpal joint also will be involved. What is Schaffer's fracture?
Schaffer's fracture is the fracture where intra-articular of the radial styloid head will be fractured along with the intra-articular which joint is affected.
Okay. So after the X-ray, what will you do?
After the X-ray,
so before shift, so this patient came to ER with fall and pain. So what will you do?
Initially give for a pain management so that we can do the examination and further. Once the pain is relieved, then we'll do the examination and we'll confirm that pulses.
So pain management, how will you manage the
by
pain?
giving PCM. Initial we gave PCM. Next we checked if the pulses and there is no neurovascular loss. Once it is confirmed, then we shifted it for a X-ray.
For X-ray. So what are the 3 ways of reducing the pain in a fracture patient? So you can plan on an X-ray. Before that you can give analgesic. Then
before procedural sedation.
Procedural sedation.
And traction and fixing it.
That is after confirming. After confirming that it is what type of fracture, we can plan on that. Before shifting for X-ray, what else? And other than IV analgesic, what else can reduce the pain? Immobilization. Splinting. Okay. And ice pack also. So how will you splint?
Parallel like what is this? Arm sling board we attach.
You can either use a straight splint. So what is the size of the splint we use for upper limb? You can use a 3 to 4 inch splint. And will you splint the entire upper limb? No. Only we are just splinting. We won't be circumferentially covering that. So 3 to 4 inch can be used for upper limb, and for lower limb you can use 5 to 6 inch splint can be used. Okay. And how much area will you immobilize?
One joint above it and one joint below
it. Okay. Then what are the other splints available for Colles fracture? If at all it is suspected Colles. Sugar tongue splint.
But that is treatment.
Sugar tongue splint can be used if it is either if it is clinically, if it is looking like a Colles fracture, we can use sugar tongue splint. It can be used as a splint, and after the immobilization it can be used for stabilization also. Okay. Then other splint is, you have the Colles splint, you have the sugar tongue splint. Sugar tongue splint is mainly for the humerus fracture. If you are using for the ulnar fracture, it is called as distal sugar tongue splint. So how will it splint?
There are 2 splints which we keep it across the forearm. And then
where will you start splinting?
From the metacarpal.
Just proximal to the metacarpophalangeal joint. Then it will cover the entire wrist, go up to the elbow, and it will come back. It will not be covering circumferentially, it will be parallel. And it will end at the mid-palmar crease. Okay. Like that you can immobilize. Okay. So you have taken the X-ray and confirm it to be Colles fracture. Then
now as the patient is the shortening is less than 5 mm and the angulation is less than 20 degrees, we can consider for closed reduction.
Okay.
And there is no communicated fracture, so we can plan for closed reduction. So in view of the closed reduction, first we need to plan for
so when will you plan if it is when will you plan just immobilization without reduction? In stable fractures, you without any dislocation, we will be just managing conservatively with immobilization. If there is some amount of dislocation, we will be planning for close reduction. Okay. So before close reduction, how will you give analgesics?
We can plan for either procedural sedation or local anesthesia. Local anesthesia, either we can give hematoma block or Bayer's block.
What is hematoma block?
In hematoma block, basically we need to load the local anesthesia and near the point of the swelling.
What local anesthesia will you take?
Lidocaine.
Percentage?
1.3%.
We take 1% lidocaine. We will be taking only 6 to 10 ml of 1% lidocaine. So depending on the percentage, the per kg weight varies. So that much only we will be giving. So how will you give
So we need to find the fractured site with the help of the tip of the needle.
Yeah. Okay.
First we sterile the area, drape it, and then with the help of the needle we'll try to trace the end of the bone point where it has fractured. Then we withdraw some blood.
You will be feeling a step-like feeling at the site of fracture. Okay.
So when we withdraw, if there is any blood coming out, it confirms that that's the point of the fracture site.
So where will you insert the needle? Ventrally, dorsally? No, dorsally. The fracture is displaced like this.
Yes.
So there will be angulation like this. So you will be inserting the needle like this. We are planning to enter inside that fractured area. There will be a hematoma. We are planning to enter inside that hematoma. So after explaining the procedure to the patient, we will have to clean that area and we will have to insert it towards that fractured area. That step-like deformity will be there. So in that we will be looking, and we will be looking for backflow. Backflow we have to see the hematoma. Usually before giving local anesthetic we won't be seeing. So since it is a hematoma block, we will have to see the blood coming out, and then we will be injecting local anesthetic. Along with that, we will have to keep the cardiac monitor and everything, because we don't want any local anesthetic toxicity. Okay.
In this case, we actually planned for procedural sedation, midazolam of 1 to 2.
So before procedural sedation, what will you arrange?
Before sedation, we have to arrange for airway management. For that, we need to be arranged, and then we need to connect the cardiac monitors. We need to take the vitals, pre-procedure vitals have to be. We have to classify as per the ASA, and then we need to start with the procedural sedation, and we need to even give fluids.
Oxygen, fluid,
Oxygen and
IV
fluids.
cannula, cardiac monitor should be done. Okay. What was used?
Midazolam of 2 mg was given, along with that fentanyl of 30 microgram was given.
What is the per kg dose of fentanyl?
Fentanyl per kg is 0.25.
0.5 to 1 microgram per kg for procedural sedation. Okay. And what is the other analgesic which we can give instead of procedural sedation? If the patient is having any contraindication for procedural sedation, we told about hematoma block, procedural sedation. What else can be done? What is Bayer's block?
Bayer's block is intravenous. We need to first apply the tourniquet, and we need to drain out we need to stop the inflow of the blood to that area, and through intraarterial we give lidocaine plus bupivacaine. Intravenous.
So, for doing Bayer's block, we need double cuff, and we will be inflating it in the arm, not here. Double cuff, like we know BP cuff is having only one cuff, so 2 cuffs are required. And before the procedure, we will have to ask the patient to lift upper limb for 3 to 4 minutes so that the flow will reduce. Then we will have to inflate which cuff, proximal or distal?
First proximal.
First we will inflate the distal cuff. Distal cuff will be inflated more than 250 to 300 mmHg. Then we will, then after that we will be inflating the proximal cuff after deflating this one. So proximal will be inflated and distal will be deflated. Then we will, so before the procedure we will have to place 2 IV cannulas. One IV cannula for giving fluids and rest of the things. Other IV cannula is just to give it IV local anesthetic, that is lignocaine. So lignocaine, usually we will be using only 0.5% of lignocaine. 3 to 6 ml of 0.5% lignocaine only will be used, and that will be given IV. Then we can start the procedure after 1 to 2 minutes. And always make sure that even though we are finishing that reduction procedure within some time, we can only release the cuff after 30 minutes. We don't want this lignocaine to go to the systemic circulation. Okay. And another thing is that if at all this patient is having any discomfort while using this proximal cuff, then we can slowly inflate the distal and inflate the deflate the proximal. Okay. So that is how we do Bayer's block. Then reduction was planned. So how will you reduce this?
First, in the case of reduction, as the mechanism of injury, same way we need to apply the traction, and then we need to extend the wrist from like
so
one.
So how
person.
will you do the traction?
One will be applying the support at the
so
fingers.
So one individual, the one who is applying the traction, has to shake hand with the patient. Okay. Another one.
And the other one at the arm, at the elbow joint.
Other one at the arm, we'll have to give the counter traction. Then
first is we need to extend, and then we need to press the bony fragment back into the position.
So one other hand, the third person's hand will be coming dorsally to put the dorsal displacement into position. Okay.
And then we need to target that 0-degree palm of flexion. There we need to fix it finally, the slab.
So the displacement will be corrected, and then after the displacement it should be pronated also, so that the deviation, radial deviation also will be corrected. So one person will be doing the traction, other one will be doing the counter traction, so that there will be a stretch in this area, and the third person will be pushing it down so that the dorsal displacement will be moved, and then we will be doing a pronation so that the radial displacement will be corrected. Okay.
After that, again we need to recheck with the X-rays.
After that, we'll have to
first do the neurological and pulses. We need to check neurovascular. We need to check, and then we need to check with the X-rays.
We need to splint it again. Then we'll have to do the check X-ray. Okay.
In this case, check X-ray showed that the positioning of the fragment is proper, and we need to advise to come after 6 weeks. Immobilization of 6 weeks is required.
Okay. So when will you plan surgical management?
In case the angulation, dorsal angulation is more than 20 degrees, or if the shortening is greater than 5 mm.
More than 5 mm to 1 centimeter, then
we need to plan for surgical, or if there is comminuted fracture
and
involving the intra-articular
joint,
and also it's not reducing on my attempted
failed immobilization, then open fractures, and if there is any if it is intra-articular joint, and if it is communicating or damaged wounds and all, or if it is involving other carpal bones, we'll have to plan on doing surgical management. Okay.
Also, as the age of the patient was 60 years and being a female, osteoporosis would be the most common complication, and this patient might have, even because of her having baseline osteoporosis, might have got a fracture at this. We need to check that levels and also correct it.
Okay. Other complications, what will you expect?
Early or late carpal tunnel syndrome can be seen usually in Colles fracture fixation, and malunion can be expected.
Then what other structures can be involved? Median nerve injury, as you told, carpal tunnel syndrome. Then there can be injury to the EPL tendon, extensor pollicis longus tendon, that can be injured. And what is Sudex osteodystrophy? That is the fixity of that area. So with physiotherapy only that will get healed. Okay. So stiffness, malunion, these things are expected. Okay. What about the management of other fractures like Barton, Smith and all?
Smith fracture also we can plan for reduction and fixation, same like Colles, but in the opposite, giving the
here the displacement is volar displacement. So we need to correct the volar displacement. Okay. And if it is failing, surgical management.
Barton's and Choffer both are surgically.
Mostly Barton fracture are surgical management. If it is involving more than the joint and other carpal bones, we'll have to do anyways. Okay, some Bartons, if it is involving less than 50% of the articular joint, then we'll plan for conservative management. Otherwise, mostly surgical. Okay. Anything else?